So thank you so much everyone for joining this ISL forum back. Really happy to have such a good turnout here in today's webinar. So we're very grateful to have can you hear me well? So I'm very grateful to have Dr. Andrea Lobene here with us. Let me give a brief introduction to Dr. Lobene before we get started with the webinar. And Dr. Lobene is an assistant professor in the Department of Health, Nutrition, and Food Sciences at FSU. Prior to joining FSU in 2024, Dr. Lobene completed her postdoctoral training at University of Delaware in the area of applied cardiovascular physiology. She received her PhD in nutrition science from Purdue University, and she's also a registered dietitian. Dr. Lobene's research is focused on how various dietary factors, especially sodium and potassium, affect cardiovascular health across lifespan. Her aims to develop and implement effective dietary interventions to improve early cardiovascular disease risk factors. She also hopes her work can contribute to improving current dietary guidelines and the policies to improve cardiovascular health at population level. Please, take away the stage, Dr. Albini, for the presentation. Thanks.
All right. Well, thank you so much. Can everyone hear me all right before I keep going? Okay, perfect. So thank you so much for the invitation to speak today about my favorite research topic, which is sodium. So for my colleagues that are on the call, you're probably gonna hear stuff that I've mentioned before, but it's my favorite thing to talk about, so I'm happy to keep talking about it. But my talk today, I'm gonna kind of provide some background information about sodium and kind of how I got interested in this topic, and then go into some work I did prior to coming to FSU, and then talk about some future direction for my work, especially related to like research topics that would affect older individuals. So it's probably not news to anyone on this call or most people in general that we know that sodium is a major contributor to cardiovascular disease burden. I think this statistic is a little old at this point, but I think this really drives home an important point of how important sodium is when we're thinking about cardiovascular health. But research has shown that globally, 1.65 million annual deaths from cardiovascular disease are attributed to sodium intakes above 2 grams per day or 2,000 milligrams per day of sodium. So these two figures are pulled from a paper that's about 12 years old at this point, but I think one thing I want to specifically highlight is how much this death from cardiovascular disease that's attributed to sodium intake overwhelmingly affects adults over the age of 70. So there's a particular interest in understanding how to kind of mitigate this problem. And we do know also that for every 1 gram or 1,000 milligram increase in sodium intake, the risk of cardiovascular disease increases by 6%. So really, truly, the more you consume when it comes to sodium, the worse your risk of cardiovascular disease becomes. So any reduction in any reduction in sodium intake can really be beneficial for cardiovascular disease risk. So when we think about sodium and cardiovascular disease, probably the first risk factor that comes to mind would be blood pressure. And this has been studied, I would say, fairly extensively. And we do know that research shows that sodium is positively associated with blood pressure. And like I said, there's a lot of research that's shown this effect, but probably one of the best landmark studies that's shown this from observational evidence is called the INTERSALT study. So this, to give you a little bit of background, this was a observational study that was conducted in about 10,000 men and women on the younger side between the ages of 20 and 59 from 32 countries. So this really was kind of a global study that assessed the relationship between sodium and electrolytes, so potassium as well, and blood pressure. And just to kind of give you the SparkNotes version, basically the results of this study showed a very strong positive association between blood pressure and 24-hour urinary sodium excretion. So for those who might not be familiar, sodium intake can be kind of hard to assess. One of the best measurements that we have for assessing sodium intake is with a 24-hour urine collection. 24-hour urinary sodium excretion serves as a very reliable biomarker of sodium intake. So essentially, the results of this study show that sodium intake is strongly correlated positively with blood pressure. So obviously, this is observational evidence, but we do also have some very strong experimental evidence that shows that reducing sodium intake can lower blood pressure. And again, there's many studies that have shown this, but probably one of the best and most highly cited studies that has shown this effect is the DASH sodium trial, which I'm sure a lot of you guys have probably heard of. But to give you guys a little bit of a reminder, this was an experimental study that was conducted in a little over 400 adult men and women with elevated blood pressure. If I remember correctly, I believe these adults were kind of middle-aged-ish. So participants who were in this DASH sodium trial were randomized to receive either a controlled, what they called a controlled diet. So it was kind of the dietary pattern was modeled after what the typical American diet looks like, or they were randomized to what we call the DASH dietary pattern that was rich in fruits and vegetables, lean meats, low-fat dairy products, things like that, general foods that we know are good for us. So participants received either one of those two dietary patterns, and within each of those dietary patterns, they received 3 different sodium levels, so in a random order. So basically, they completed each of these sodium levels throughout the study. One of the sodium levels that was provided to participants was called the high sodium level. So this was set to 3,500 milligrams per day. The intermediate sodium level, which is 2,300 milligrams per day, or the low sodium level, which was set to 1,200 milligrams per day. So this figure here kind of shows the primary results of the study. So I'll kind of walk you through it real quick. On the x-axis, we have the 3 sodium levels, experimental sodium levels for the study. So we have the high sodium level, the intermediate sodium level, and the low sodium level. And then on the y-axis here, we have the systolic blood pressure measurements that were taken at the end of each diet. The changes in blood pressure across the different sodium levels for the people that were on the control diet is represented by these red arrows here. And then the changes in blood pressure in the people that were on the DASH diet is represented by these yellow arrows here. So basically, kind of the take-home point from this study is that they found that reducing sodium intake significantly reduces blood pressure. So that was, at the time, obviously the study is a little bit old at this point, but at this time, this was probably the strongest experimental evidence that we've ever seen that showed that reducing sodium intake clearly is connected to reducing blood pressure. Another thing that they noted in this study is that they found that there tended to be a steeper decline in blood pressure when sodium intakes were between this 2,300 milligram level and the 1,200 milligram level, which is kind of starting to show that dose response effect that likely somewhere keeping your sodium intake somewhere between 2,300 milligrams per day and 1,200 milligrams, this would probably be considered optimal. That's kind of where you get the most bang for your buck when it comes to reducing your sodium intake. So the sodium intake recommendations that we have currently are based on the studies that I just cited, as well as many others that have kind of really pointed to what we think is the optimal level for sodium intake. And we have a couple of different sodium intake recommendations in the US that differ a little bit based on your health status and your risk factors. So for generally healthy adults, so people who have no real disease history, no history of cardiovascular disease, no other underlying conditions that would affect their sodium needs, the recommendation is to keep your sodium intake below 2,300 milligrams per day to reduce the risk of cardiovascular disease. However, there are a lot of people, based on American Heart Association guidelines, who could potentially benefit from reducing their sodium intake even more. So for some individuals, reducing sodium intake to about 1,500 milligrams per day can result in even greater reductions in blood pressure and also reduce risk for cardiovascular disease. And for these specific groups, it's recommended to kind of keep our sodium intake close to 1,500 milligrams per day. So individuals who might benefit from an even lower reduction of sodium would be individuals with hypertension, individuals who are Black, individuals with diabetes, individuals with chronic kidney disease, as well as individuals aged 51 or older. So basically, older adults would also fall into this category as well. So as you can tell, there's a lot of people in our country and globally who could potentially benefit from reducing their sodium intake even further. Obviously, everyone could benefit, but for some people, it's even more important. Unfortunately, most people consume too much sodium, and this is kind of something I'm very interested in particular. So I think the statistic is that more than 86% of US adults exceed the 2,300 milligram per day sodium intake recommendation. I don't know what the stat is off the top of my head for how many exceed 1,500, but I'm guessing almost everyone. So reducing sodium intake is very hard. So this graph is pulled from NHANES data that shows what the average intake of sodium is currently and how it's kind of changed over time. So when we're looking at all adults in the US, current intakes sit around 3,200 milligrams per day. Different studies might show different levels, but this is kind of about where most people are sitting. We divide it up by sex. Males tend to have higher sodium intakes, and then females tend to have lower. But regardless, pretty much everyone is exceeding current sodium intake recommendations. And when we look at where that sodium in our diet is coming from, this pie graph here kind of shows where those top sources of sodium in our diet are from. And the overwhelming source of sodium that we're getting from our diet is from food that we consume that's prepared outside of our home. So this is kind of a broad category, but it includes things like restaurant foods, like pre-prepared frozen meals you would buy at the grocery store, basically anything that we did not purchase as in the form of a whole food and then can like prepare at our own home. So this is obviously a very wide category of foods. I also do kind of want to highlight, a lot of people might not know this, but sodium is also just inherent in a lot of foods. Sodium is an essential nutrient, so we can't consume no sodium. So there are a lot of foods that, regardless if you're eating a completely whole food diet, you're still going to be getting some sodium in our food that just occurs naturally. And I want to point out too that the relative contribution of sodium added at the table or sodium added when we're cooking at home isn't as high as people probably think it is. I mean, it's definitely not helping, but the sodium that we typically would add, like from our salt shaker at the table, really isn't the biggest contributor to our diet when it comes to sodium intake. The biggest contributors are really foods that we did not prepare ourselves. Something else I want to point out too is that a lot of people might be thinking, like, when it comes to sodium intake, if my blood pressure is normal, there's really no reason I need to be concerned about sodium. Like, this doesn't matter to me. Clearly, my blood pressure is fine. And I do want to caution people who think that way and point out that sodium intake impairs other cardiovascular disease risk factors beyond just blood pressure. So no one is really out of the woods when it comes to sodium intake and cardiovascular disease risk. One of the most important risk factors that I'm interested in my lab and that I'm kind of using for most of my research is something called endothelial function, which I'll talk about in just a second. But basically, endothelial function is referring to like the health of our blood vessels, which is a really key risk factor for future cardiovascular events like heart attacks and strokes and things like that. So we know that sodium intake impairs cardiovascular health independent of blood pressure. And this was shown this is a little old at this point, but using a kind of proof of concept study that was actually conducted at the University of Delaware before my time. So this study that kind of demonstrated this effect was a controlled feeding study in healthy salt-resistant adults who are generally like younger adults. So I don't think I mentioned this earlier, but when I'm using the term controlled feeding study, what I mean by that is that the researchers who conducted the study very carefully designed menus and actually prepared all food for participants and gave it to them. So this is, in the nutrition science world, this is a really powerful study design because the researchers basically have complete control, assuming participants are compliant with the intervention. They have basically complete control over what the participants are eating. So we can be very confident that the results that we're seeing are truly due to the changes in dietary intake that we, as the researchers, manipulated. So participants in this study were generally healthy young adults, and they consumed 2 controlled diets in random order for 7 days each. One was a high sodium diet, which was provided about 7,000 to 8,000 milligrams per day of sodium. So obviously, when we're thinking about the intakes relative to recommendations, this is a very high amount of sodium. And then they also consumed a low sodium diet, which was about 460 milligrams per day. So this was truly a proof of concept study because the amounts of sodium were pretty extreme in either direction. And at the end of both diets, the researchers in this study measured endothelial function. So I have kind of like a cartoonish figure here that shows how this data is actually collected. But to give you a little bit of introduction, the method that we use in our lab and that was also used in this study is called brachial artery flow mediated dilation. So with this test, we kind of like create a hyperemic stimulus, which should, in normal healthy people, should cause the diameter of your artery to increase. That if we see an increase in the diameter of the artery through this stud or through this test, it would indicate a healthy artery. So a smaller change in the diameter of the artery, or a smaller increase, I should say, in the diameter of the artery would indicate that endothelial function is impaired. And this figure here that I have, this is actually a screenshot from like an ultrasound image. We use an ultrasound to capture the brachial artery in this test. And this is kind of if what you would see when you're doing this test with the ultrasound. So to kind of give you an overview of the results here from this study, we have the low sodium diet and the high sodium diet represented on the x-axis here. And the y-axis represents the endothelium dependent dilation or the change in diameter of the artery. So just kind of as a reminder to orient you, a larger number is good. That would indicate a healthier artery, and a smaller number would be bad. It would indicate that there's some impairments in endothelial function. And so we saw here that endothelial function or the endothelium dependent dilation was significantly reduced when participants consumed the high sodium diet compared to the low sodium diet. So clearly sodium was having an effect on this cardiovascular disease risk factor. But a really important point that I want to point out here is that the participants in this study, their blood pressure actually did not change in response to the sodium intervention. I'm not going to go into too much detail about salt-resistant blood pressure because that's not really the point of my talk, but even in people who have normal blood pressure, who are otherwise healthy, and who aren't experiencing changes in blood pressure with changes in sodium intake, they still need to be cognizant, I should say, of their sodium intake because it's kind of affecting other things behind the scenes when we think about cardiovascular disease risk. So the previous study that I cited was in younger adults, but we also know that reducing sodium intake can improve endothelial function in older adults. So there's not a lot of clinical evidence that I'm aware of that's shown this, but we do at least have one study that was conducted previously that has shown this. So we know that there was a study that was conducted in adults with elevated blood pressure this was kind of more of like a middle-aged to older adult cohort. And participants in this study consumed 2 diets for 5 weeks in random order. So one was what we would call a normal sodium diet. So kind of around 1,500 milligrams per day from their diet plus 2,300 milligrams per day from salt pills. So the total intake that they got from their diet and from salt pills was approximately what people normally consume. And then one group consumed a low sodium diet with placebo pills. So kind of consuming a sodium intake that was more similar to the recommended sodium intake or sort of that ideal sodium intake that we mentioned before. In this study, systolic blood pressure did decrease or was lower on the low sodium diet compared to the normal sodium diet. So unlike the younger adults, older adults do tend to see changes in blood pressure when we have changes in sodium intake. So we did see changes in blood pressure, but they also saw very significant changes in brachial artery flow-mediated dilation. So that's that same test that I mentioned before that assesses endothelial function. So on the normal sodium diet, we see an endothelial function or FMD value that was kind of close to like 3.5% change. And then on the lower sodium diet, we see a much higher brachial artery flow-mediated dilation. So a much greater increase in the diameter of the artery, which is a good thing. That's an important thing we want to see. In fact, the study cited that flow-mediated dilation was 68% higher on the low sodium diet. So that's a pretty big difference. So we have clinical evidence that sodium impairs this risk factor, brachial artery flow-mediated dilation, in both young adults and older adults. So this is something that we definitely want to be concerned about. The problem is with kind of making broad recommendations to reduce sodium intake is that in reality, reducing sodium intake is very challenging. And there's been a lot of public health efforts, research efforts that have been focused on trying to get people to lower their sodium intake because we know high sodium intake, bad. We know that all the things that it can affect. So the obvious solution is just help people lower their sodium intake, but that's much easier said than done. In general, some mixed results, but in general, population level sodium reduction interventions have showed mixed results. So these would be things like public awareness campaigns, large-scale health education efforts. So stuff that's kind of happening at the public health level to try to get large amounts of people to lower their sodium intake have not really been particularly successful. At the more individual level, there have been some behavior change interventions that have shown maybe a little bit of moderate success with reducing sodium intake. I know that this is a big graph, but this is the results from a meta-analysis of a bunch of different behavior change interventions that kind of summarize the results from all of these studies. And we do see that among these studies, there was somewhat of a significant reduction in urinary sodium excretion. So again, this kind of marker of sodium intake, which is equivalent to about a 12% reduction below baseline. So at the individual level, behavior change interventions can be helpful for reducing sodium intake. But one of the problems with these studies is that a lot of them don't last very long. So kind of a missing piece to this puzzle is whether or not these changes that have been successful in these more short-term behavior change interventions can actually be sustained long-term. So I'm not going to go into this in too much detail today, but this particular question is something I'm interested in exploring in the future. So all of the data that I've presented so far has kind of led me to some of the key questions that guided the research I did before coming to FSU, as well as my current work. So we know that excess dietary sodium impairs cardiovascular health. So we know that there's risk factors when it comes to blood pressure. And we also know that it affects endothelial function and the health of our blood vessels. But we also know that it is difficult for individuals to reduce their sodium intake. Could be successful, but whether or not those changes can be sustained long term is still pretty unknown. So a big question then is, if the interventions that we have available to us aren't that great, what can we do to mitigate the effects of excess dietary sodium? So a thought that a kind of a question that I worked on during my postdoctoral work and that I'm still kind of investigating is, what if instead of focusing on reducing sodium intake at the individual level, which is hard and potentially unsustainable, what if instead we focus on increasing the intake of cardioprotective nutrients? So instead of focusing on getting people to lower their intake of something, what if instead we switch gears and think about trying to get people to increase their intake of something? I think anecdotally, most people like to be told to eat more of something and not eat less of something. So from that sense, there's some promise there. A key nutrient that I'm particularly interested in and that has been investigated fairly well at this point is potassium. So potassium, we know, independently reduces the risk for cardiovascular disease. So this figure, again, comes from a meta-analysis, and it shows the results of this meta-analysis show that in general, higher potassium intakes are associated with reduced blood pressure in adults with hypertension. So in adults who already have elevated blood pressure, increasing potassium intake can be effective at helping them lower their blood pressure. In addition, we also have shown from that same study that higher potassium intakes are associated with a lower risk of stroke and may be associated with a lower risk of cardiovascular disease overall. So when it comes to cardiovascular health and cardiovascular disease risk factors, we know that increasing potassium intake is a good thing. Something that's interesting is we don't eat nutrients in isolation. Anytime we eat any piece of food, we're consuming a lot of nutrients all at the same time. So one thing that's a topic of particular interest is the sodium to potassium intake ratio. So the ratio of these two these two nutrients that kind of have opposite effects on our cardiovascular health, and how this ratio in particular might affect cardiovascular disease risk. And observational evidence seems to show that this ratio is actually more important than the intake of each nutrient individually. So one of the key studies that has actually shown this to be true is the Trials of Hypertension Prevention Follow-up Study. So this was a large observational study that was conducted in about 2,300 individuals who basically participated in this kind of like long-term cohort study. The primary endpoint of this follow-up, like long-term observational study, was the incidence of cardiovascular disease. And the time that they followed up with these participants was about 5 to 10 years. So the overall results of this study showed that there was an increased urinary sodium excretion. So again, kind of this biomarker of intake is associated with increased cardiovascular disease, but the results were not significant. So there was like a trend there, but they weren't quite like statistically significant. And they also showed that increased urinary potassium excretion, which for context also serves as a good biomarker of intake. So this increase in potassium intake is associated with decreased cardiovascular disease risk. But again, the results were not significant. So there was a trend, but like not quite statistically significant. However, the key finding of the study is that there was a statistically significant linear relationship between the sodium potassium ratio and cardiovascular disease risk. So basically, when we consider both of these nutrients together, we are able to more strongly predict cardiovascular disease risk than if we examine sodium or potassium individually. So the sodium potassium ratio, when you think about it kind of like from a mathematical perspective, um, in general, a lower, or excuse me, a lower ratio would be more beneficial. A lower ratio would indicate that either sodium intake is lower or potassium intake is higher. And then conversely, like a higher ratio would be considered kind of negative when we think about dietary intake. So this provides really strong evidence that we should really be looking at both of these nutrients together when we're thinking about cardiovascular disease risk and mitigating these risk factors. So we have shown there is evidence to show that potassium offsets sodium-induced blood pressure elevation. So not only do these two nutrients like work together to increase cardiovascular disease risk, there's also some evidence to show that potassium might actually counteract the effects of sodium, which is very helpful to know. So when sodium intake is high, so when we're consuming more sodium realistically than we should be, a higher potassium intake is associated with lower blood pressure, so suggesting that potassium may actually blunt the effects of a high sodium intake. So that's kind of what this figure here that I'm showing shows. So this study showed that when sodium intake is high, so above that recommended 2,300 milligrams per day, as urinary potassium excretion increases, so again, this biomarker of intake, the blood pressure levels decrease. When sodium intake is within normal ranges, there really doesn't seem to be as much of an effect of potassium. Doesn't mean it's not beneficial, but there seems to be a very powerful kind of like blunting effect of potassium on blood pressure especially when sodium intake is high. One of the another important study that's actually demonstrated this sort of indirectly, this kind of blunting effect of potassium on blood pressure is actually the DASH sodium trial. So that study that I cited earlier on. So the DASH diet, because it's rich in fruits, vegetables, dairy products, things like that, it's also by design a high potassium diet. So they actually showed, so in the DASH sodium trial, going back to this kind of like primary results from the study, blood pressure was consistently lower on the DASH diet compared to the control diet, even at the highest sodium intake level. So I'll kind of reorient you to this figure here. We had the 3 sodium levels that they provided to participants in the study. And then we have systolic blood pressure on the y-axis here. The red arrows represent changes in blood pressure on the control diet, which, because it was designed to look like a typical American diet, was pretty low in potassium. Most Americans don't meet the current potassium intake recommendations. And then the DASH diet, on the other hand, was very high in potassium. It had about 4,700 milligrams of potassium per day. And we see when we look at these kind of dotted arrows here, at every single sodium intake level, blood pressure was significantly lower on this high potassium dietary pattern compared to the low potassium dietary pattern. So we also have some pretty strong observational evidence, or experimental evidence, I should say, that potassium might blunt the effect of sodium on blood pressure. So then the next question I kind of was interested in is, if potassium can blunt the effects of sodium on blood pressure, can potassium also blunt the effects of sodium on endothelial function, which again is kind of one of those other underlying cardiovascular disease risk factors that is very predictive of future cardiovascular events. So this figure here shows the overall study design of the study that I worked on when I was a postdoctoral researcher at the University of Delaware. So the kind of SparkNotes version of this study is that we were able to show that potassium offsets sodium-induced vascular dysfunction in young adults. So let me kind of walk you through the design of this study, and then I'll show you what my overall results were. So this was a study in young adults between the ages of 18 and 45 who are generally healthy, have normal blood pressure levels, no history of cardiovascular disease or other chronic diseases and things like that. Participants in this study completed 3 controlled diets in random order. So again, we provided all food to participants throughout this entire study. One of the diets that they consumed was a low sodium diet with placebo pills, which I'll address in a second. When they were on this diet, they were getting about between 2,000 and 2,100 milligrams of potassium per day. So a little bit on kind of like the low moderate end of potassium intake. One of the other diets they consumed was a high sodium diet plus placebo pills. So on this diet, they were getting about 7,000 milligrams of sodium per day from their diet and about 2,100 milligrams of potassium. The third diet that they consumed was a high sodium diet. So again, we're getting 7,000 milligrams of sodium per day plus potassium chloride pills. And between the combination of the dietary intake with the potassium supplements that they were giving them, participants on this diet were getting 4,700 milligrams of potassium total. So this is pretty similar to the amount of potassium the participants got in that DASH sodium trial. So participants in the study consumed all three of these diets for 10 days each in a random order. So everyone's got them in a slightly different order. And then on the last day of their diet, or after the last day of their diet, I should say, they came to our lab and we measured brachial artery flow-mediated dilation. So ultimately what we did was compare flow-mediated dilation at the end of each diet to see how these different amounts of sodium and potassium affect endothelial function. And this graph shows kind of the overall findings from this study. So let me orient you to it a little bit because I know it kind of looks like chaos. But on this blue bar right here represents the brachial artery flow-mediated dilation values when participants were on kind of that lower sodium, lower potassium diet. So kind of like our control diet, I should say. This red bar here represents the flow-mediated dilation values that we collected when participants were on the high sodium, moderate potassium diet. So this comparison here allowed us to examine the effects of sodium kind of on its own on endothelial function. And then this final bar here represents the FMD values that we recorded when participants were on the high sodium diet while also taking the potassium supplements. And basically what we found is that when participants increased their sodium intake, FMD decreased significantly. So there was a significant difference between FMD on this diet compared to the low sodium diet as well as the high potassium diet. And then interestingly, when we added the potassium supplements on top of the high sodium diet, that kind of like negative effect of sodium basically went away. So the FMD values that we recorded on this potassium supplemented diet were not different and were pretty much almost exactly the same as what we would observe on the low sodium diet. So this was kind of really interesting results. And I was very excited that we found this because we basically showed that, at least in this population, adding potassium to a high sodium diet is pretty much equally as effective as just lowering your sodium intake. So that was really helpful or really exciting for me to find. A notable gap. So this was the results I got from my postdoctoral work. Now, as here at FSU, my goal is to kind of take this work a step further and explore these effects in other populations. And one population that I'm particularly interested in exploring is older adults, just because there's more interesting stuff going on in that population that could make us question whether or not these results would be the same, whether or not they'd be more exaggerated. So that's kind of where I'm headed now. There hasn't been, interestingly, a lot of work that's examined the relationship between sodium and potassium in older adults, or even in middle-aged adults for that matter. There's only, to my knowledge, this one study that looked at sodium and potassium supplementation on endothelial function. I should clarify that sodium and potassium were not supplemented together in this study, but were supplemented separately. So just to give you a brief spark notes of what this study did, participants in this study were either middle-aged or older adults between, I think the ages were like 40 to 80. So we're kind of spanning a large age gap there. And participants in this study consumed 3 diets in random order for 4 weeks each. So one was a 2,000 milligram sodium diet, a 2,000 milligram potassium diet, plus 3,000 milligrams from sodium. So basically a sodium supplemented diet to make this a high sodium diet. One was a 2,000 milligram sodium diet, a 2,000 milligram potassium diet, plus potassium supplements. And then the third diet was sort of like their control diet, just 2,000 milligrams of sodium, 2,000 milligrams of potassium, plus a placebo. And basically the results that they found were that on average, changes, again, they measured brachial artery flow-mediated dilation at the end of these diets. And they found that on average, there were minimal changes in FMD with the sodium supplementation compared to placebo. You could see maybe like a little bit of a trend that FMD tend to deteriorate or tend to decrease with the increase in sodium. But interestingly, they did find that FMD, or that brachial artery flow mediated dilation value, improved significantly with the potassium supplementation compared to placebo. So these results are very promising, and they do tend to show that adding potassium to the diet of an older adult could improve endothelial function, which is interesting. A major gap in this study that I'm hoping to fill is that they didn't have an intervention where they looked at both a high sodium intake and a high potassium intake together. They sort of looked at both nutrients individually, but they didn't really compare or examine what would happen if both of them were high. So that's a major gap in our understanding of kind of where we would go from here. Another kind of caveat or thing or kind of asterisk to this study, as well as the work I did during my postdoc, is that the sodium and potassium, or in this case, potassium in particular, were increased with supplements. So I do want to point out here, I'm definitely not endorsing taking large amounts of potassium supplements. So please, no one leave this talk thinking that they need to go to the drugstore and just clear the shelves of potassium supplements. In this case, potassium supplements were given as like kind of like a proof of concept and to very specifically pinpoint the effects of potassium without getting other nutrients involved. The amount of potassium supplements you would have to take to meet current intake recommendations is a lot. So I'm not recommending that. Definitely recommending potassium from whole foods. If you take nothing else away from this talk, focus on whole foods. And that's actually kind of a gap in the literature that I'm hoping to fill with some of the current work that I'm doing. So I want to know basically, is a whole food intervention that's focused on potassium effective in older adults? So this is kind of a particularly interesting population to study because we know that the link between sodium and potassium could be of particular importance. One of the reasons is because when we think about endothelial function and the health of our blood vessels, this endothelial function does tend to decrease with age for a number of reasons. So younger adults are sort of at an advantage because their endothelial function is already going to be a little bit better. Older adults, endothelial function starts to decline. So there's more at stake, I guess I should say, when we think about blood vessel health in this population. And then when we're thinking about older adults, females in particular are kind of at increased risk for cardiovascular disease and in particular endothelial function, because we know that post-menopause with that loss of estrogen, females experience a greater decline in endothelial function with age compared to men. So once we lose estrogen after a certain age, endothelial function really starts to decline. So all of this really highlights why studying this effect in older adults is extremely important because there's potentially more at stake in this population. So based on what I've done previously and based on other work that's out there, there's a few gaps in the literature that I'm planning to fill with some current work that I'm doing. So one is in particular, how does increasing potassium intake using whole foods affect endothelial function in older adults? So again, we kind of have that previous study that was done with potassium supplements. Recommending potassium supplements across the board is probably not the best idea for a number of reasons that if anybody has questions about, I can answer. But really focusing on increasing the intake of foods that are high in potassium, like how is that going to be helpful for this particular population? And then another gap is basically how does sodium and potassium actually interact to affect endothelial function in older adults? So they seem to have effects independently, and there's evidence to show that, but when we manipulate both at the same time, what happens? So that's the current study that I'm recruiting for actually as we speak. So I just kind of hard launched this study like a couple weeks ago to actually fill that gap in our knowledge and answer those particular research questions. So let me talk to you a little bit about what this study will look like and shameless plug for anybody who might want to participate or has anyone who wants to participate. But this study is sort of going to be a direct spin-off of my postdoc work using whole foods. So for this study, I'm recruiting adults between the ages of 55 and 75. For the females in the study in particular, they must be at least 1 year post-menopause. So again, we know that menopause has an effect on endothelial function. So I want to specifically target the females that are enrolled in the study, specifically those who are already post-menopause. Obviously, males, this doesn't apply to you, still eligible, but females must be post-menopause. And then the adults in the study will be generally healthy. Exclusion criteria for this study would be a BMI of greater than 35, a seated blood pressure above 135/85, and a current diagnosis or history of cardiovascular disease or kidney disease are two key exclusion criteria. Taking any blood pressure lowering medications, and then also following a restrictive diet. The reason that I have that particular exclusion criteria in there is because this study will be a controlled feeding study. So fortunately, we have the resources here to be able to conduct those types of studies. So I want to make sure that participants would be able to eat the food that we give them, essentially. So this figure shows the overall study design for the study. So let me kind of walk you through it a little bit. Interested participants will obviously provide written informed consent, and then they'll be screened to confirm that they are actually eligible for our study. So we have a few other exclusion criteria. We'll just, obviously screen our participants to make sure they meet our inclusion criteria. And then participants will be randomized to the order in which they consume 3 different diets. So we will be providing 3 different diets to participants that will be each 10 days long. One of the diets will be a low sodium, low potassium diet. So again, this is sort of like a control diet. One will be a high sodium, low potassium diet, so we can look at the independent effects of sodium. And then one will be a high sodium, high potassium diet, so that we can examine how potassium might potentially counteract the effects of a high sodium diet. Participants will consume these diets for 10 days each. On day 11, they'll come to our lab where we will measure brachial artery flow-mediated dilation and a few other tests. And then there will be a 14-day washout period between diets. So when participants enroll in the study, they'll consume a 10-day diet, wait at least 14 days, consume diet number 2, wait at least 14 days, consume diet number 3. So my goal here is to examine whether or not sodium and potassium might interact to affect cardiovascular health, and in particular, if potassium can potentially counteract the effects of a high sodium diet in this population. So this study just started. Looking forward to those results because I'm super excited to see if the results that I got in the young adults are replicated in older adults, or if we might see something different. So a future direction for this work, I'm super excited for the older adults controlled feeding study that I'm doing. The future direction for this line of work basically is to see then if changes in potassium intake, especially an increase in potassium intake, are actually achievable kind of out in the wild, if you will. So outside of a laboratory setting, without free food being delivered to you, if you're the one making dietary changes, can you actually achieve the amounts of potassium we would want you to achieve in order to adequately reduce cardiovascular disease risk? So because I have strong preliminary data in younger adults, I'm actually starting a study right now, basically, that's testing this question in younger adults. So this study is going to be about a 6-month-long intervention where participants who enroll in the study will be assigned to receive education focused on increasing potassium intake or education focused on lowering their sodium intake. Participants will complete 4 weeks of individualized education with a registered dietitian. And then every 2 months, we're going to follow up with the participants in this study to see, A, if they're achieving the dietary changes we hope that they will, and then B, are we actually seeing changes in endothelial function and other cardiovascular disease risk factors from these hopefully self-selected dietary changes. So actively working on this study in younger adults now. My goal then long-term would be to apply hopefully a similar study design if we're successful in middle-aged and older adults as well. So long-term, I really want to provide some good evidence that increasing potassium intake, if my hypothesis is correct, is beneficial and it's achievable in adults kind of across the lifespan. So I want to take a minute and give a shameless plug for the facilities that I have in my lab space. If there's anyone on this call who might be interested in collaborating, I just kind of want to give you a little bit of an overview of what resources I have available in case there's any shared interest. So in my lab, I have a dedicated clinical laboratory space where we do the FMD testing as well as other cardiovascular measurements. We do have an adjustable exam bed. I focused on FMD in this talk, but I do also have other equipment for measuring arterial stiffness and other cardiovascular disease risk factors like ambulatory blood pressure, as well as seated blood pressure, physical activity monitors, and also a little device that can measure body composition. I have also a small dedicated like dietary assessment space that we can use. So we have a private consultation room where we can meet one-on-one with participants for research purposes, for education purposes, things like that. We have specialized software in the lab that we actually use to plan the menus for all of our controlled feeding studies. So everything gets very carefully calculated and prepared to make sure that we're giving participants the amount of sodium, potassium, calories, other nutrients that we think we are. And then we also have specialized software that we use for dietary assessment measurements for measuring intakes from diet records as well as 24-hour recalls. And then we also have some like life-size looking food models to help assist with nutrition education for those types of studies. And then I also have a dedicated wet lab space where we have an electrolyte analyzer, which we use primarily for urinary sodium and potassium excretion, so we can have those good biomarkers of intake. And then I also have like a Piccolo Express to run various laboratory panels depending on what you're interested in. So shameless plug if anyone's interested in collaborating. And then I do want to take a minute, of course, to acknowledge I'm kind of amassing like an army of students in my lab who are really helpful and wonderful and doing all of the work that I've just cited before. Um, both PhD, masters, and undergraduate students have all been wonderful. And then, of course, the funding sources that have made all of this work, past, present, and future, possible. And then, of course, a special shout out to our research participants because our participants are obviously key for helping us get all of the data that we need. But so thank you to everyone who's participated in our studies or will participate. So I will end here and I'm happy to answer any questions that anyone might have.
Great. Thanks so much, Dr. Lobene, for this really exciting research and a series of important findings that are important for the longevity and the health of individuals, especially both younger adults and older adults. So we have a few minutes for questions. So if you have any questions, you can either just open your mic and just directly ask or type a question in the chat.
Yeah, could I ask a couple of questions? Thanks. That's a very interesting line of research. I had a couple of questions. One of them is, what does a high potassium whole food diet look like? Are there particular items in the diet that carry much of the weight in terms of providing potassium?
Yeah, thank you for asking that because that wasn't something I specifically mentioned in here. But typically, foods that are high in potassium are going to be, in general, like fruits, vegetables, and dairy products tend to be the biggest contributors of potassium
Okay.
to our diet. Not all of them are going to be created equal, but I think one fun fact I like to share is that potatoes are actually one of the best sources of potassium, especially like on the like vegetable side, which who doesn't like potatoes, so people love hearing that. But in general, I would say if we eat foods that we know are good for us, they probably have potassium in them, which I know might be an oversimplification. But one thing I want to point out too, so thank you for bringing this up, is that one of the reasons it's so important to test like a whole food type intervention rather than potassium supplements is because foods that are high in potassium are also high in a lot of other things that are good for us. So they tend to be higher in fiber, obviously, which we know is very good for cardiovascular health. They tend to be higher in other micronutrients, so not potassium, calcium, magnesium. They, depending on how they're prepared, also tend to be lower in sodium. So there's also, all the phytonutrients and stuff that are in them that are still being explored. So whole foods have so much potential to be beneficial for cardiovascular health. Potassium obviously being one of the main reasons, but others as well. So thank you for asking that. But yeah, to answer your question, fruits, vegetables, and like dairy products tend to be the highest in potassium.
Okay, thanks. That's helpful. One note I would make is that I was surprised about potatoes, but unfortunately, I suspect most Americans, when they eat potatoes, do it in the form of fries, which tend to be very heavily sodium salted.
Yeah,
Um,
obviously, yeah, one of the ways we prepare potatoes you know, might not be ideal, but then the question is if they're still high in potassium, does it counteract that effect? I don't know.
exactly, yeah.
Food for thought.
Okay, the second question, though, was concerning particularly what role, if any, hydration might play in this process. Because I
Mm,
know when you sweat a lot, if you're an athlete and you're running and so on, you tend to excrete salt.
yeah.
And I don't know, I'm not knowledgeable, you are. Do you equally excrete potassium as well as sodium in terms of excretion? In other words, what sort of a potential mediating or moderating effect would fluid intake play in this process?
Yeah. So my colleague Joe Watso just posted a paper in the chat. So
Okay,
the idea of potentially sweating out sodium as a means to almost like offset the effects of consuming too much sodium is a topic that I'm very interested in, is actually one that Joe is actively investigating. So to my knowledge, I don't know if we have good evidence of how sweating could alter these effects, but I think that's something that's definitely worth exploring because, like I said, reducing sodium intake is very challenging. So if there's, in addition to dietary factors that could change, like increasing potassium, if there's other lifestyle modifications that we could make that would offset these effects, such as sweating, for example, like could we also see benefits to endothelial function, cardiovascular health just from sweating, whether that be in the presence of like exercise, for example, versus not. So I think you raise a good point, and that's definitely an area of research that some of my colleagues and I guess I, as part of that, will be exploring. So stay tuned, I guess.
okay. Just a quick follow-on comment, I guess. Older adults in general tend not to be adequately hydrated.
Mm-hmm.
Average, they're in a state of modest dehydration, and
Mm-hmm.
that's why I was wondering about the role of fluid intake, particularly water intake, because
Yeah.
is that likely to affect, for instance, your measurements in older adults when they come in slightly dehydrated on average?
Yeah, we do measure hydration status
Okay,
in our participants, so that's something we would account for. I don't know if I have a specific answer to your question, but that's at least when we do these studies in older adults, that is data we would be collecting.
okay, good. All right, thanks.
Thank you.
Thank you. There's a question in the chat. Are there previous and recent evidence on association between sodium intake and heart rate variability in older adults both with and without cardiovascular diseases? And also changes in age, heart rate variations may reflect alteration in the autonomic regulations of blood pressure. HRV is a measure
Mhm.
of cardiovascular health.
Yeah, I don't know off the top of my head if there's any evidence of this directly in older adults. I know that there has been some work in younger adults. I'd have to go back and look at the papers to know for sure. I don't know if Joe Watso would know the answer to this question because he's also done some work in this area. I don't know. My instinct is to say that there probably is a relationship, but I'm not as familiar with that literature off the top of my head. I have to do a little homework to answer that question. But that is definitely an important research question. So if no one's done anything related to that, that's definitely worth exploring.
Thank you. And another question from the attendees. So
Maybe I'll
yeah,
ask
sorry.
one question.
Mhm.
Thank you, Andrea. This was such a nice educational lecture for me. I mean, I'm very much interested in nutrition, and I hear a lot about sodium, potassium, but this was very much updating for me. So thank you. And I have a very simple question, which I always hear at ASN nutrition conferences also whenever there's a talk about um, sodium and vascular disease. So, are there any studies that have revealed individual absolute effects of sodium versus potassium? Because most of the studies, some of those studies you also reviewed, and most of the studies that have linked sodium with cardiovascular disease risk, they always said, conclude that yes, high sodium intake is a risk factor for vascular disease, but at the same time, it's not clear if it's high sodium or low potassium in the same.
Mm-hmm.
And
Yeah.
likewise, when we do intervention and a person reduces the sodium intake, so the benefit is because of less sodium or more potassium. So it's
Yeah.
like chicken and egg theory. And I was wondering, like, are there any studies, whether preclinical or clinical, that have, unveiled those individual, mechanistic effects of sodium, potassium, and also chloride in that
Hmm.
context?
Yeah. So thinking about the individual effects of sodium and potassium, I think your question really highlights the importance of studying both nutrients together and not individually because one will go back, but we do know that the sodium potassium intake ratio is a strong predictor of cardiovascular disease. So clearly studying both is really important, but it is a good question to be asking of whether or not, if we're thinking about altering that ratio, would doing it by lowering sodium or would doing it by increasing potassium, like, would both be equally as effective? Is it better to do it one way versus the other? If we do a little bit of both, would we also see effects? So I think that probably with some like epidemiological data would be worth exploring, which is, I don't know, that was actually a question I was pondering earlier because I think that was definitely something worth exploring. Um, I don't know if I have a clear-cut answer to your question. I would guess I'm from like an RD sort of public health messaging sort of response. The response I would probably give is doing both reducing sodium intake and increasing potassium intake is good. So I'm not necessarily recommending only one or only the other. But in terms of the hard evidence that's showing which is better, or I don't know if I have a specific answer to your question, but I think your point does highlight the importance of studying both nutrients together. And I suspect doing so could lead to more questions than answers, which is a good thing and definitely worth exploring more.
Yeah, thank you. I know there are not too many studies in that area, but I was just wondering, maybe you are more updated than me. So thank you.
Yeah,
Yeah.
it's worth exploring. And it's like, that's also sort of a question I've been tossing around in my head. So, I don't know, stay tuned. Maybe I'll come up with another study that can address that question directly.
Thank you. Yeah.
Thank you so much, Dr. Lobene. I have just have a quick question. I wonder, in the nutrition research area, do people consider micro-randomized trials where you change your interventions during the kind of the study phase? Because I see that in your study you have multiple checkpoints on those biomarkers, and you kind of give people different interventions. Do people make changes to this randomization procedure or interventions on the fly based on their measurements, or it's
For
more
the
static?
For the type of study that I'm doing at the moment, no. However, I don't remember the exact technique, but when I was at the American Society for Nutrition conference last year, I believe, someone gave a talk, and I want to follow up with them because they had a very specific way for like more behavioral type intervention. So, like for a controlled feeding study, changing the intervention midway would not be ideal, but for more
Mm.
behavior type interventions, I know that in the nutrition world, there are studies where they will sort of randomize people to like the behavioral intervention that's most optimal for them, and then kind of use that type of study design, which is something I don't know enough about it to speak knowledgeably about it, but it's something I'm interested in pursuing with some of my future work when we're thinking about like developing ways to implement this at the public health level, being able to help people in a way that is most optimal for them would be good. So I know that those types of studies exist. I don't know enough about them to explain specific circumstances that they are used, but it's something I'm interested in as well.
Yeah, sure. Thanks so much for that also. Um, okay, I think we're right on time. So I'd like to thank Dr. Angelo Bini again for this wonderful presentation. And again, we'll be posting this video on our YouTube channel and also share through social media. And we'll, if you have other questions, please follow up with Dr. Lobini. And please also be on the lookout for our future events. Thanks so much, everyone, for joining. Hope you have a nice, wonderful Wednesday. Bye, everyone.